The topic for our live this morning, we will be covering part 5 of our AMH series, so we'll just dive straight into the questions. My first question for you, Dr. Rusty, is what is the role of an AMH in the diagnosis of the cause of infertility?
Yeah, excellent question. As a fertility specialist, when we get new patient referral, we look at a few things immediately. First thing we check is the age of female patient. Second thing we check is the AMH level. So then we look at other things, because these two major factors determines their success in fertility treatment. So, and that's AMH is one of the critical factors. And the third thing, we look at the female ultrasound scan report, how healthy their uterus. Next thing, we look at their partner's semen analysis report. So we look at these four things and we estimate their likelihood of success, and immediately we can tell how likely this couple is going to achieve successful pregnancy with fertility treatment. So, and so these are major building blocks of couples fertility, and of course female fertility, which is their age, which determines the egg quality, their AMH level, which determines the egg reserve, egg quantity, and uterine health, which will determine the chance of implantation of each transferred embryo. Then partner's semen analysis report that explains how easy to create high-grade embryos together, taking into account egg quality and quantity. This is why AMH is a critical part of any fertility treatment. This is why AMH is one of the main tools of any fertility specialist who provides care to patients with infertility. So yes, AMH, it can be used in diagnosis of cause of infertility. So because in extremes of egg reserve, the problems start happening with the release of eggs. So the extreme of egg reserve means very high egg reserve, very low egg reserve. So a very high egg reserve this is a women with a PCOS. They have a very high egg reserve, very high AMH, very high antral follicle count. Any given time they have multiple, maybe 50, 60, 70, 80 follicles in their ovaries, and all these follicles competing to ovulate. And because of high AMH, they cannot ovulate, because AMH is a suppressant. They just stops follicles going through the activation before they become dominant and ovulate. It doesn't let follicles go beyond 10 centimeter stage. When you scan them, you can see lots of follicles sitting all smaller than 10 millimeters, not 10 centimeters, 10 millimeters. So yes, and in patients also with extremely low egg reserve, is a diminished egg reserve or critically low egg reserve, they start missing ovulation. They start having irregular period. That can be cause of infertility. So we use AMH to establish the level of egg reserve, whether this patient has a very high egg reserve and as a result may not be ovulating, or a critically low egg reserve, as a result may not be ovulating. Of course, you need to have ovulation to achieve natural conception. So, and the second question we ask is how often you have a period. If someone says, I have a period every 3-4 months, and if the AMH is high, that's obvious. This couple probably, provided they don't have any other cause, like semen analysis is normal, they're having regular intercourse, uterus is healthy, they don't have severe endometriosis, then I assume they are not having a successful pregnancy because of PCOS, because AMH is so high, not letting them to ovulate frequently enough, and they are releasing egg maybe every 2-3 months. Although they've been trying whole year, actually she might have released only 3-4 eggs, and this is why we need to offer treatment, which is ovulation induction for PCOS, with tablets or injections. So if answer is the same, if a patient says to me, I have a period every 2-3 months, then I check the AMH. If it's critically low, let us say 1.0 or less than 0.6, that indicates this patient has a critically low egg reserve, and that's why she's not ovulating. So the treatment for this patient is very different, which is IVF, and trying to achieve successful pregnancy before she completely runs out of egg reserve. Yes, AMH tells us whether the patient has an extremely high or extremely low egg reserve, as a result may not be releasing eggs. So this is there's various tools for use of AMH, but mainly in terms of diagnosis of infertility, is used for these two purposes. And also, women with a not critically low egg reserve, but low egg reserve can have infertility. Let us say your AMH is 2.5 picomoliters. So when you do ultrasound scan for antral follicle count, AFC will be like 6 or 7 with in average, with AMH of 2.5 picomoliters. So, and especially if the patient's age is older, that indicates she's releasing eggs, maybe poor quality eggs. This is why not getting successful pregnancy naturally. Why? Because when you have an antral follicle of 7, when the selection of egg happens, selection happens out of one of the 6-7, which is closest to 10 millimeters. Maybe there are like only 2, 3, or a couple of follicles closer to the 10 millimeters. When you have for same age, if your AMH is 15, then you have maybe 4 total antral follicles, 20, 25, but maybe 5, 6 follicles sitting ready for selection. When you select the follicle, which is close to 10 millimeters, you select the healthiest one. If you have a bigger pool, you are likely to select healthier eggs. So, and yes, a low egg reserve can cause issue with the quality of eggs which is selected for natural conception. For IVF, it doesn't matter much because you stimulate all of those follicles, and let us say you do egg collection, you get like 4 or 5 eggs out of 6, 7 follicles, then you can overcome this by selecting all of those follicles. Yes, so AMH can establish the cause of infertility, establishing whether ovulation is happening or not because of high egg reserve or low egg reserve, and also whether healthier eggs are getting selected when couples are trying to conceive naturally if they have a very low egg reserve. Yes.
Thank you so much, Dr. Rusty. So it seems like AMH does play a massive role in fertility as we are learning through this series. So my next question is, how do you use the AMH test to plan overall fertility treatment?
Yes, so looking at so you can get the same destination, which is getting baby, from the different directions. Yeah, destination is the same. You want to have a baby, so you can have you can approach from various ways. You can have a shortcut. You can have a longer way to get to the baby. So, and there are different routes to the same success. So when, as a fertility specialist, when we see couples, we try to find the most optimal route to the success. Yes, we know very likely we'll get success. In most couples who come for fertility treatment, most couples will get success. But what is the most optimal route to the success, which is least stressful, fastest, least costly? So, and we formulate together with the couple, we discuss and formulate that, look, this is the best route for you to success. This intervention, yes, or this treatment. So in patients, in women with a low egg reserve, if the AMH is so low, they have to get to the destination quickly, because they have to use the time as a most critical resource. Because as AMH goes down, which is egg reserve goes down, it becomes harder and harder to achieve successful pregnancy, even with IVF. Because quantity of eggs you get in IVF is by far quality, and the quantity of eggs you get in IVF by far is the biggest factor which determines your success in IVF. So, and if your egg reserve drops, that you start getting less and less eggs, it becomes harder and harder. So in patients with a low egg reserve, we ask them to use most effective intervention, which is IVF. And also in IVF, you can take a different strategies. Let us say I have a patient with a low AMH, very low AMH, and then they have a uterine problem. Let's say multiple uterine fibroids. So the one approach for this patient is, let us say you need to solve the uterine fibroid because it's so many fibroids distorting the cavity. Likelihood of successful implantation is very low. So you say, look, we got like window, we need to get embryos, get the eggs out and create embryos and freeze the embryos. You freeze multiple high-grade embryos. So next, maybe, I don't know, 3, 4, 5 cycles of IVF, depending on how easily they can create the high-grade embryos. Then you sort out the fibroid. Because when you treat the fibroid, of course, you have a waiting list for the surgery. It's major surgery. Then, and a lot of fibroid surgeries, you cannot conceive whole year. So then you got the eggs out and embryos out, you know this embryos, depending on how many high grades you get, gives this couple at least maybe 90%, 95% chance. So while they are waiting for the fibroid surgery, they do embryo banking, then sort out fibroid, then wait another year until this uterus healed, then transfer, knowing that decline of the AMH egg resorb, let us say egg resorb, doesn't affect their future chance. So there's different strategies you can take, but AMH helps us to plan treatment. Of course, if AMH is very high because of PCOS, yes, we plan to do ovulation induction using Clomid or letrozole or FSH. So that also helps us to plan fertility treatment. So that is a very highly individualized. It's not possible to write on textbooks or guidelines or protocols. It's impossible because each couple's fertility is unique. It's like fingerprint. There are no two couples in the world have the same fertility, and this is why each couples in treatment or advice to be give to each couple is individualized. So one of the tools we use to individualize advice is AMH and antral follicle count.
Thank you, Dr. Asti. My final question this morning is, how do you use the AMH test in IUI?
Yes. So in terms of using AMH test in IUI, and also we use for ovulation induction. So, which is related. Essentially, when you use AMH test for ovulation induction, let us say ovulation induction, then I will explain IUI. So in patients with PCOS who don't have ovulation at all, let us say they have amenorrhea, they don't have a period for more than 6 months, or they ovulate every 2-3 months. So, and they are not ovulating, provided they don't have any other cause of infertility like tubal problem or partner sperm. So then ovulation induction is best treatment. So when we use AMH to estimate first how easy to achieve ovulation induction. Yeah. Second is to reduce to determine the dose of ovulation induction drugs. Third is to reduce the risk of ovarian hyperstimulation syndrome. So AMH used for ovulation induction for 3 purposes: to determine actually who needs ovulation induction. If your AMH is low and if you're having infrequent period, then it's very unlikely you'll have anovulation. Yeah. So because patients with anovulation, which means you're not ovulating, almost always have a high AMH. Why? Because AMH is the one which stops them from ovulating. So if you have a low AMH and if you think that you're not ovulating, you need to review this diagnosis. You need to do progesterone tests, to establish probably you're ovulating. So yes, first is who needs ovulation induction. Second, how likely we can achieve ovulation induction. Third, dose of ovulation drugs. Fourth is to reduce risk of ovarian hyperstimulation in ovulation induction. So essentially, in terms of how likely you can achieve ovulation induction depends on AMH levels. Why? Because if you have extremely high AMH, it's very difficult to achieve ovulation induction. Let us say you have a PCOS and your AMH is like 110 picomoliters. So when you do ultrasound scan for antral follicle count, you have like 80s, 90s small follicles. So AMH is so high, it's difficult to reach that ceiling of AMH to achieve ovulation induction. Yes, you can try. So that's my third point, is to use to determine the dose of ovulation induction. So which means you need to start with a higher dose of Clomid or letrozole. So normally if you start with 1 tablet of letrozole, 2.5 milligrams, in this patient's probably 2.5 milligrams is waste of whole months. You need to start with a higher dose, 5 milligrams of letrozole from the first months. So because for that to reach to that level of AMH, you need very high FSH. The high FSH, the letrozole's job is to induce the production of FSH, natural FSH. So to reach such a high level of FSH, you need to start with a higher dose of letrozole. So, and if you reach then the perfect, you found the right dose, you monitor, provided you're producing 1 or 2 follicles, then that's the right dose for you. So, and yes, to determine, and also if it doesn't work, then you may need to use FSH actual injection, gonal-f or menopur, instead of letrozole or clomid, because you may not be able to reach high enough level of FSH to induce ovulation in PCOS with very high AMH. So you try 2 tablets, if it doesn't work, 3 tablets, 7.5 milligram doesn't work, then you move straight to the menopur or gonal-f or Purigon, one of those FSH drugs, to achieve ovulation induction. So, and also AMH level is used to estimate risk of ovarian hyperstimulation syndrome in ovulation induction. Yes, in ovulation induction, also women can have a OHSS, not only in IVF. Even clomid or letrozole can give you OHSS, although it's rare, but it can. And if this is a women who have a very high AMH levels, the ones who have a who are at risk of OHSS, OHSS if they do ovulation induction. Why? Because you use a high dose like 7.5 milligrams of letrozole, then when you ovulate, you may ovulate multiple follicles. You may activate multiple follicles. This way, if you have very high AMH, you need to have a monitoring of ovulation induction, at least until you establish what is the right dose for you. Especially if you're using high dose of letrozole, 7.5 milligrams, you need to monitor to ensure you are not developing OHSS. And also, if you're using FSH drugs with very high AMHs, you start with a low dose, let us say 50 units, 75 units, then you don't respond because of high AMH, you keep increasing to 100 units and 125 units, suddenly you over response. Why? Because the ceiling of AMH pushes to your follicles so much. Once your FSH goes up, external or internal FSH goes up, suddenly there's like 20, 30 follicles waiting for that level of FSH, and then all take off. And suddenly you can have ovarian hyperstimulation syndrome. So, and we use AMH for these 4 purposes. In IUI is the same. For IUI, if AMH is normal and patients having patients having a regular period, that means she's ovulating. She's ovulating naturally. You don't need to do induced ovulation induced IUI. So ovulation induced IUI, which means you do natural IUI. So, and in patients who have a PCOS or anovulation plus they're needing IUI, we use the same strategy to determine what dose of stimulation drugs they need, or ovulation induction drugs, letrozole or clomid, they need to induce ovulation successfully. So tomorrow we can cover use of AMH in IVF. That's very extensive, so we cannot cover today. On tomorrow's live stream, we will go very deep into use of AMH in IVF, which is very detailed live stream. So far today we covered use of AMH in diagnosis of infertility, treatment planning in couples with infertility, and the third, in use of AMH in ovulation induction in IUI. If you listen to the yesterday's live stream, we discussed use of AMH in fertility preservation, which is egg freezing and embryo freezing.
Amazing. Thank you so much, Dr. Asti. I hope those that jumped on found this live very valuable. And as always, the screen recording of it will be published to Dr. Asti's social media channels on YouTube, Instagram, and TikTok. And as Dr. Asti mentioned, tomorrow we will be covering the role of AMH in IVF. So if you were interested in learning more about that, please jump on tomorrow morning. Thank you so much, Dr. Asti, and we'll see you guys tomorrow.
Thank you. Thanks everyone for joining. Thank you.
Bye.